Welcome to our tea discussion for the Lung Cancer Network of Malaysia World Lung Cancer Day Series 2023. So I hope you're able to enjoy candid discussions between healthcare professionals in the management of lung cancer patients, and feel free to leave your comments in the comment box. Thank you. Hello, good afternoon, Dr. Felicia. How are you?
I'm good. Hi, Dr. Tho. Thanks for asking me to come here.
Okay, so thanks for doing this interview. Obviously, World Lung Cancer Day is on the 1st of August, and it will be good if maybe we can have a discussion and bring up some of the issues that our patients face so that the wider audience can get an idea about the challenges and the successes and the joys that we face in our work and our patients face in their journey, in their lung cancer patient journey. So the first question I want to maybe ask you is, what do you do? And maybe you can tell us about your job.
Well, I'm a palliative care physician. Okay, been in this field for the past 20 years. Right, so my background is I started off with home care first.
Okay.
I was in hospices, different hospices for more than 10 years before I become a private practitioner here in Beacon. And for now, what I do is I see patients in the hospital, and the referee are normally from oncologists like yourself, Dr. Tho, that come to send patient to us so that we can work together to take care of patient. Then after 2, that's where my home care starts, and I go to the house of patients so that we continue the care at home. So I think in our hospital, I think both of us are aware that we try to make it as seamless as possible so that the care that we have in the hospital extend to the home as well.
Okay.
Right.
So you see both patients that in hospital as well as when they go home. So you see the full spectrum of their journey. Is that right?
Yeah. So some of our patients in the hospital, especially those facing some more challenges like pain, end of life care, the oncologist would like us to continue the care because then we also can talk to you about it, let's say at home.
Okay.
Because I think the relationship initially is always with the oncologist first.
Okay.
So they have this relationship and we want to maintain that relationship. So even when we are home, when we're seeing them, we always say, like for example, Dr. Tho send regards, if anything you need to get to Dr. Tho, I can relay the messages, But once they are more ill, then we literally take over in a sense that, our management in the pain, working with the journey. But we do still consult with our oncologist if needed. Yeah.
So what made you go into palliative care? How did you choose this profession?
I think I would say the profession chose me. I want to live many, many times. As you know, it's very stressful, but yet I think I always believe it's a vocation, something that God has chosen for me. But it all started when I was back home in my Sitiawan Perak. When I first involved, a lot of the patients are usually my parents' friend or my friends' parents. So that get me very interested in trying to extend the help. And because we were not trained, so I choose to continue my training in Selayang Hospital under the palliative care team there.
Okay.
And later on under one of the big hospice that also trained me up to be a palliative care physician.
Okay.
Yeah. How about you, Dr. Tho? Tell me about you.
About myself? I have been in oncology for about 25 years now. Working in the field. I think I chose oncology because it is a field that is always changing. There are new innovations, new methods, drugs that we can use to improve our patients' lives, make them live longer, fight the cancer. It's something which is very intellectually satisfying. But at the same time, we deal with patients, as you know, who are facing very real challenges. Cancer evokes a very emotional response in people. Even though the disease may be as severe as kidney disease or heart disease, but the word cancer evokes a lot of fear, a lot of uncertainty in our patients, and it's something which is, it gives a dimension of challenge to the physician, not just dealing with the physical, but also the emotional and the psychological. Yeah. Yeah,
I think I agree with you, because the moment they mention cancer, a lot of patients and family are so fearful, right?
Yeah.
And talking about, oh, is that's the end, my family or my friends who died from cancer.
Yes.
So I think when you were saying they evoke a lot of emotion, I totally agree with you. And I think there's a lot of new things, even for us, we're also learning every day that, in cancer treatment, it not only prolong life, now it improve quality of life.
Yeah.
Yeah. So right now, I think if we more awareness, then people seek help faster.
Yes.
They get treatment faster, and I think the quality is much more better.
Yes.
Dr. Tho, I know that you are one of the oncologists who are very interested in dealing with lung cancer, and I know that the cases that we see, a lot of patients have a lot of symptoms. Would you mind sharing with me what kind of symptoms do they experience?
So lung cancer patients can experience symptoms from their main cancer in the lung, for example, causing the lung function to go down and they feel short of breath. Sometimes the tumor produces blood and they cough up blood. It can produce cough. It can produce pain in that area. But also the tumor may actually spread to other parts of the body, which may cause different types of symptoms. So one of the common symptoms, for example, is it spreads to the bone. And the bone has a lot of pain fibers, and sometimes it can cause bone pain, which is not related to the people may not think it's related to the lung cancer. One of the problems we face is that these symptoms, for example, a cough, shortness of breath, can be experienced by normal people as well. In fact, most people who experience that symptom do not turn out to have lung cancer. Most of the time, it is a simple chest infection, for example. But I think probably what differentiates it is these symptoms don't go away with time. So if people have a lung infection and they get treated with antibiotics, they normally get better. But if it doesn't get better, then I think the patients should really go and seek further investigations.
How long do you think the public should be, how long before you say, oh, this is the time to actually seek to look for a doctor to find out what is wrong? Is there a timeline, like in terms of weeks or months, that you ask the patient to be more aware?
I think there's no fixed timeline, but I think in general, if over weeks it doesn't go away, or in fact gets worse, then I think then the alarm bells should ring and you should really seek more medical help and investigation for your problem.
All right. But if they have a family member that has cancer in the family, do you think they need to be more alert and more aware?
Yes, I think in general, cancer has an association with the genetics. That means there's an inherited tendency to develop cancer. In lung cancer, for example, we know that your risk of lung cancer increases if you have a first-degree relative with lung cancer, and of course increases further if you have more than one first-degree relative.
I see. Besides the lung symptoms that you mentioned, and are there other associated symptoms that you can pull it together? For example, we know that lung cancer or cancer patient, they lost weight, they lost appetite. Is there anything else that brings so that they can go and seek their help faster?
I think what you mentioned is true. So people who have lung cancer, quite a number of such patients will have weight loss and may have associated anorexia, which is loss of appetite. Talking about symptoms, now I want to ask you as a palliative care doctor, when the patients come to you with these symptoms, how do you manage them? For example, shortness of breath. So that's very common in our patients. How do you manage that?
Well, I think what you mentioned earlier about it can lead, the symptom could be manifested in the one symptom, but it could be many causes. For example, if a patient that comes to me and say, oh, it's very difficult for me to breathe, So in my mind, it could be from the lung cancer itself, it could be from chest infection, as you mentioned, but it also could be related to lack of blood, like anemia, or anxiety attack. So I think the first thing that we need to identify is to find out the source of the problem.
Right.
For example, if it's at home, we know that patients have, for example, patient shortness of breath. The first thing they have in mind is, oh, let's go to the hospital. But then when they actually contacted us, if they're my home patient, they were like, okay, what are other causes? Do you have fever? You know, so we try to rule out what are the common ones. But I find that a lot of our patients actually have a lot of anxiety, and that aggravate the symptoms. So a lot of time before they come to the hospital, we're like, okay, let's just think about this, you know, take a deep breath, you know, how's your home ventilation, you know, do you have a pulse oximeter with you? If your oxygen shows that 98%, then I'm not too worried, you know. So if let's say, oh, it really dropped to below 95, say, oh, then maybe this is the time for you to go to the hospital. But other than that, we're trying to rule out other non-medical, I would say non-life-threatening problem first, settle them before they come and seek for help.
So what you're saying is that actually the feeling of breathlessness can be induced by the patient's emotional state. Is that correct?
Yeah.
Okay.
The psychosomatic is quite common. That means they have so much of fear, and they have this anticipatory, you know, before they go to hospital, the BP shoot up, you know, before they come to us, they are more breathless. We check the sugar, we check everything, you know, your oxygen is 98, why are you panting, you know, you check the lung, everything is clear. So there is definitely a very strong emotional component related to the symptoms when they come to see us. So we usually don't take the blood pressure, at least for me, in the clinic, whatever blood pressure they have, oxygen level, I don't trust. I say, tell me what's at home. So if they say, oh, my BP is 60, come here 170, I say, I'm not really too concerned about it because you are actually having white coat syndrome.
Yes.
So yeah, so that's how we first eliminate what is the not life-threatening, then we know that we can deal with them on the spot first, then we ask them to come back to see us.
So white coat syndrome is high blood pressure when you see a doctor.
Yes.
Okay.
Yeah.
So that's fascinating. So what you're saying is, as a doctor, we shouldn't take one measurement in isolation. We should really look at the patient from the point of view of their overall medical health, psychological well-being, and also the factors that influence their day-to-day life.
Yes, definitely, definitely. So we train our family and patients to actually do some vitals at home and bring the record and show it to us. Then we just want to do a comparison what happened at home and what happened in the hospital. And then we find that in the hospital, even in the ward, we find that the blood pressure is always on the high side. But once we see them at home, their readings and their records are usually quite acceptable. So we do at home sometimes need to adjust some of the medication. For example, we start some blood pressure medication in the hospital, but at home the BP is so good, I tend to stop it as well or reduce it as well. Yeah.
If not, you over-treat the patient, isn't it?
Yeah.
So one of the other problems that my patients sometimes have is that the tumor may actually cause some pain, and the pain could be temporary. You know, maybe they present with pain at the start, then we give them treatment, the tumor shrinks, then the pain goes away. But one of the tools that we have to manage pain is opiate analgesia, and patients sometimes have a fear of taking opiate analgesia for fear of getting addicted to the to the opiates. Can you explain to us what opiate analgesia is, and how we should use it for our patients?
I think it's a very relevant question. The reason is because opioids are a group of pain medication that we use very commonly among oncologists and palliative care physician team, because it is a painkiller. It is what we call as analgesia. But opioid, there are many things in the opioid group. We have morphine, we have oxycodone, we have fentanyl, and all these are very strong medication. Right. I think in the past, the fear has created is because when people are dying, they use morphine, right? So every time we start a pain medication like a morphine, people think they are dying, which is not true, because we use it just like you have a headache, I give you Panadol. You know, but if a tumor pain, at now, opioid is still the best option, right? However, it also
so it's a very good option to really get the control of the pain.
Yes, it's very good control.
And the goal of that is to improve quality of life.
Yes. Okay. And one more thing about opioid is morphine is it helps in shortness of breath. A lot of patients that are having a lot of breathlessness are settled by opioid as well. All right. So, but I think what we need to do is to create this awareness, not to be so fearful. And for us to start opioid I think as a doctors, we have to be very careful not to start too high dose.
Yes.
And then I always say start low, go slow, so that we titrate according to the patient's need. However, we also must understand from the patient's psychological point of view. So let's say you put her on opioid or morphine. In front of you, they say, yes, 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 doctor, I'll take anything for the pain. But half of the time when I see them at home, they stop morphine. Then when you check with them, it's that the fear is so strong that they just refuse to take it. And it's okay, because there are many types of other medication that we can use for pain. So we really need to have the cooperation from the patient and the family. It's patient willing, family not willing, to get them to understand why we started, how it works, how do we titrate.
But is it true that people will then become addicted to the opiates and dependent on them and can never get off? Is that true?
I think it is a very strong myth. The reason is because, as you said, let's say you refer a patient to me. You're doing the treatment. I start opioid, I start morphine, right? I give regular morphine because there's a pain. But after the radiotherapy, the pain goes away. I take it off. I gradually taper it and take it off. So it's not for end of life care, right? And then secondly, to your question, it can be taken off, right? But if the patient didn't get better, the disease progresses, it becomes more serious, then we need to increase the dose of the morphine. It's really not about dependency, it's just that the cancer cell has become so much that we need to increase the dose. So it is really I'm not worried about addiction, because as long as you have pain, you won't get addicted to the morphine. So that is something that we need to be aware of, even as physicians as well as public, that the morphine helps with pain and breathlessness.
Okay, are there any other methods which don't involve drugs that can help our patients? So, for example, breathing exercises, or meditation, or prayer, or acupuncture, or traditional medicine. So these are things which a lot of patients always ask us about.
All right, we will always try to use the non-medical or non-medicine first, non-pharmacological first, is because it's to build patients' trust initially, right? So we must make sure that, we must find the source of the problem. If let's say we can mediate in a way that, more ventilation in the house, cooler temperature, all right? Breathing exercises. So we teach them pulse string breathing exercises.
What's that?
Pulse string is literally trying to help them to reduce the respiratory rate. So what we do is we ask them to just sit very still, all right? Then we breathe in through our nose. Then we breathe out, but our mouth will be like a pulse that is stringed.
So a narrow opening.
It's also called goldfish breathing. All right. The reason is because the intake and the output have to be longer.
Right.
We are trying to help them to actually slow down their breathing, reduce the respiratory rate, and that will also reduce the heart rate. And then we will practice till they are calmer. So that is one way, the breathing exercises that we teach our patients how to do it. Then another thing is that we use mindfulness. All right, so we are asking them not to think too far ahead and not to think about the past, but focus really on the breathing or their surrounding. And of course, we are always talking about prayers. We do talk about different aromatherapy, massages. So those are the non-medicine therapy, non-pharmacological therapy that we can complement into our medical treatment.
How about acupuncture? So I know some patients, they feel that it helps in certain positions if they've, have a strained muscle, and acupuncture seem to help them. What do you think about that?
I think it's a very good idea. So what we want to know is what's your platelet count. If you have very low platelet count, this is one of the contraindications.
So we don't want the needle to cause bleeding.
Bleeding, yes. Then we have hematoma, then we have bleeding problems. So once we know the blood is all okay, all right, then we want to know whether it is related to the nerve or muscle stiffness. I think one of our colleagues, Dr. Kun, do dry needling, and we find that dry needling or acupuncture helps in pain, especially muscle spasm, muscle tightness. So what it does is it relaxes the muscle, so we take away one of the component of pain away. All right. So acupuncture for pain, it works. Some say that it works for breathing as well. All right, but you must know the points in which it is to be
the right position.
Yeah. All right. So I do believe in acupuncture.
Okay. Yeah. And now some patients, they prefer to, instead of being in hospital all the time, they would like to try and spend as much time at home as possible in a familiar environment where family and friends maybe have an easier time to come and visit them and encourage them. What kind of things can you do, or can we help patients to allow them to be able to go home?
All right. I think in the disease trajectory, we want to see where they are. If you're talking about the early part, I find that they want to come to hospital to see the oncologist because they have this trust. So I always tell my oncologist friend, you have to see them even though they are palliative care or they are doing home care, because otherwise they feel the abandonment.
Absolutely.
Yeah. So at home, what we can do is we can actually go to the house. All right. What we assess is the interaction between the family member. I think what is important is everybody thought they want to go home. But when you go home, sometimes the environment is not conducive.
Right.
They have very poor support. All right. They are very anxious family member.
Right.
All right. So sometimes when we send them home without support, actually they get more nervous.
Okay.
All right. Then you will see that they tends to come back to the hospital very often.
Right.
All right. So what the home care can do is to go into this environment and try to actually assess and see, okay, what is going on and how do we try to mitigate some of the problem.
Okay.
And if we can give them tools that they can, for example, you know where to get the oxygen, you know where to get the bed.
Okay.
You know.
How can they have oxygen at home?
Yeah. So we have oxygen tank, which is you need to be refilled, and we have the oxygen concentrator. So if we refer to hospices, they are actually free of charge. But some patients prefer to rent it. So we have a rental system in which we will give them the vendor's contact number and arrange for oxygen to be sent at home.
Right.
Yeah. Okay. Right. But I think with COVID, a lot of people have oxygen concentrator at home already.
Yes.
Yeah.
I think the pharmacies ran out of concentrators at one point.
At one point, yeah. So I think that's how we can actually assess and help them at home.
Okay.
And if we are talking about end-of-life care, yes, a lot of patients prefer to go back to be surrounded by the family member. It's very cultural. They want to be surrounded by the loved one, but it's also very spiritual. Because a lot of time they want their pastors to come in, their imam to come in, to pray for them, They want to have a church group to be with them at all time, to support them. So as far as we can, we will support them at home, all right? And then prepare the medication for end-of-life care for them.
Okay.
Yeah.
So you mentioned a very interesting point that sometimes family members may not be fully up to speed about the condition, and that leads to a lot of anxiety. So do you find that it helps to actually bring all the family members together and have a briefing or multiple briefings so that everyone understands the situation? Do you find it helps?
Yeah, I think we do it a lot in the hospital and at home. We call it family conference.
Family conference.
Yeah, so I think we have a lot of children overseas.
Yes, nowadays, yes.
We have a lot of children that don't want to meet but want to make decision.
Right.
Yeah, so when I find that during my consult or my visit, I find that if I want to do something, there are people talk a lot, then I will say, okay, let's meet and just clarify where we are and what is your concern.
Because everyone may have a different angle or perception, and may not necessarily understand the big picture, isn't it?
Yes, I think a lot of them are not around, so they feel very guilty. So they want to contribute, but yet they can't, so they start to question. So what we do is like, if those children are in KL, then we do a family conference physically, but we also invite those overseas to do teleconsult. That means we're having a family conference with them online, all right? I find that a lot of time, the reason why they can be so-called labeled as difficult or challenging family member is because they may not understand. So by giving them the latest information, all right, and then explaining to them what we do, most of them will come to terms, and most of them will agree. And I will always say, choose one spokesperson, so that I don't have to repeat so many things. For me, I have no issue of them recording me during the family conference. So I said, you can use this message, all right? You can tell other families who's not around, but this is our goal. This is what we want to achieve. If you have any different opinion, you have to voice it soon. You know? Otherwise, at the end, when things are turning very ill, all right, my primary concern is the patient. Okay, I only speak to the person who is in charge. Yeah, it's very hard to have to speak to 10 people.
Yeah, absolutely. It probably confuses the issue, isn't it? And I think probably sometimes the patient will then nominate, you know, one or two individuals to be the main decision makers in the process, isn't it? Of course, there are some times where not all the family members get along, and that's life, that's family dynamics. But that can also sometimes make the medical management of the patient difficult. So I suppose, you know, there are many challenges in dealing with this condition. How
about Dr. Tho, can you also share with me, because a lot of my patients, like, you know, if I see them at home, it's like, you know, oh, Dr. Felicia, I already done my chemo, I don't want chemo, other treatment or not. I said, oh, this is not my field, I need to check with my oncologist. So can you tell me, for lung cancer patient, all right, everybody is so scared of chemo, is there any, how is it treated? Would you share with us how is it treated?
So I think we live in the era, especially the last 5 to 10 years, of a lot of innovation in lung cancer. You're right, maybe 10, 20 years ago, all we had was chemotherapy, surgery and radiotherapy. So now we have immunotherapy, we have targeted therapy, we have very focused radiotherapy called radiosurgery. So these are really pushing the boundaries of what we can offer our patients. We'll start with targeted therapy. Targeted therapy are medications designed to target specific proteins that arise from very specific mutations in the cancer. So with every lung cancer patient we see nowadays, it's not good enough just to do a scan of the body to see how big the cancer is, and then just do a simple biopsy. We need to actually send that biopsy off for molecular testing to actually look at the genes that are driving the cancer to grow. So if we do find a particular gene and we have a particular drug to match, so then that becomes really a very powerful weapon to target that particular cancer. And a lot of these targeted therapies are in a tablet form, so very convenient. The patient does not require to be in hospital, to have drips. We can actually prescribe them the medication, and they can go home and administer it as a normal medication. The other big innovation that we have in lung cancer is immunotherapy. So we understand now that cancer cells are very good at avoiding the immune system. Our immune system functions to detect and eliminate these cancer cells because they're actually foreign. They're not part of, you know, our normal constitution. But these cancer cells develop a resistance to our immune system. So we have now medications that reactivate our immune system to target these cancer cells. And that has been a very huge innovation. I have patients with stage 4 lung cancer who are doing very well, 8 to 10 years, after the after immunotherapy, and this is not something that we were able to do 2 decades ago. It's completely changed the way we approach our patients. So, but it does not mean that there's no role for chemotherapy or radiotherapy. In fact, we have advances in chemotherapy and radiotherapy to make them have less side effects. So the actual chemotherapy drugs that we use nowadays have advanced also, and it's not correct to say chemotherapy, you will definitely get side effects. Some patients actually experience very minimal, if no, side effects, probably due to the innovation in the type of drug we give, as well as the supportive medication, and with help from your team to support the patient through the treatment. So very good anti-vomiting medication, anti-swelling medication, anti-allergy medication. So this has also reduced the toxicity or the side effects of our treatment.
All right, thank you so much. This is something that my patient always asks me. Is targeted therapy and immunotherapy has less side effect compared to chemo? But what you said just now is because of the advancement in chemotherapy, so it is also difficult to compare. But generally, do you think immuno and targeted have very little side effect?
I think the side effects, I wouldn't say less side effects. I would say different side effects, because any treatment that we offer patients has the potential to cause side effects, and each is managed differently, and each treatment that we give has a potential for serious side effects. So this is something that your doctor needs to explain to you carefully, and you should consider it carefully before you agree to go ahead treatment. So it's not true that targeted therapy and immunotherapy has less side effects than chemo.
I see. So I think another question that a patient usually asks is like, after one treatment, can I check whether my tumor is already reduced after one cycle? So I think the practice is that you do a little bit more, then you compare do a scan later, right? So my patient is like, why is my doctor not scanning me after one cycle? Would you like to explain that to the public?
I think it's completely understandable that if you have started on a particular treatment, you will want to know whether it's working or not. I can understand completely, but sometimes these medications, not sometimes, most of the time, they take some time to work, because once you start a treatment, it takes some time to get into the tumor, to start to kill it, and it takes a while before you can actually see the shrinkage. So your doctor may only do a scan a few weeks or few months after you start the treatment, because it takes that long. The other thing we do not want to do is to scan you too often, because I think the radiation involved in the scanning process may not be beneficial to patients.
All right, thank you. I think that's very clear. So I hope that the information can be passed out to the patients and their family.
So, okay, Dr. Felicia, can I ask you, as you've been in this field for a while, what are some of the biggest joys that you've had? And what would you like to, as a final message, leave to our audience today?
Right. I think for me, in palliative care, you really see the humanity part of life,
Yes.
The ability to help someone with pain. Patient will be screaming. Then after one day, you can control their pain, and they can smile at you. You really feel that you have contributed something in their journey. And if a patient is dying, we are able to make things better for them during the journey. We know we can't cure them, but yet when they are passing away, if we can see a peaceful death, they're surrounded by their loved one, it gives us a great satisfaction to us that, we know that if we are not there to help them, they may not experience that kind of transition, right?
Yes.
So those are the things that keep us coming back. You know, I told you that I wanted to leave many, many times.
Yes.
But every time I think about it, God reminded me that, you know, you are there to do something for the people, and I think you should continue. So I think I'll continue to do what I do until I can't do anymore. All right.
Well, that's great that you, even despite a very, very, well, it's a very stressful environment that you work in, but obviously you see the benefits that you bring to the people you're trying to help. So that's a fantastic attitude and way of looking at your job. But I can fully understand that it is very stressful on a day-to-day basis.
Yeah. How about you? What brings you the joy in your job?
So I think I would echo your sentiments. Being able to connect with my patients, being able to connect with them on a human level, and to really understand not just their physical challenges, but also their emotional and psychological challenges, and to be able to walk through with them in their cancer journey. I echo your sentiments, but also from my point of view, with the tremendous innovation that we have in science and technology in the management and treatment of lung cancers, I'm seeing results which I have never seen before in my life. So I think that motivates me to carry on treating patients, learning more about new technology, doing research. We do research here in this hospital to really be able to utilize all the different technologies for the benefit of our patients.
Oh, that's fantastic. Yeah. Please continue to do so.
Thank you very much. And have a good weekend. And thank you so much.
Thank you for inviting. All right.